Hello, YouTube. My name is Hans, and I am starting a UWorld Step 2 review series. The goal of this series is to review some questions that are particularly challenging for me, and by walking you through these questions, I hope to deepen my own understanding of these problems as well. Feel free to follow along with me when I do these questions and try your hand at answering these questions as well. Today, I'll be starting with OB-GYN. This is a section that has given me a lot of issues before in the past. I've really enjoyed my rotation, but I felt like it was very rare for me to actually see a lot of the pathology that is actually tested on the exam. As a result of that, I often forget about important details that are heavily tested. OB-GYN is not super high yield on the actual step 2 exam. I believe only 5 to 10% of questions are actually going to be about OB-GYN. However, when you're taking the test, always feels like a lot more than that. It's the topic that's not very heavily covered in step 1. As a result, this area is going to be challenging for many students. I hope that at the end of this session, you and I will both get a better understanding of some of the high yield OB-GYN questions. Today, I'll just be focusing on questions that I have gotten wrong in the past. I'm going to be doing everything on tutor mode so I can discuss it with you. And let's get started. All right, so for this question, I like to first look at the question as well as the answer choices so I know what I'm up against. What is the most likely diagnosis in this question? So a lot of diseases here. So I'm going to be looking at diagnosis. This is a 19-year-old woman with amenorrhea for the last 5 months. All right. Patient underwent menarche at age 14, had regular periods before. So this is a case of secondary amenorrhea as opposed to primary. We know this because she's already had periods. No headaches, visual disturbances, heat intolerance, palpitations, hot flashes, or night sweats. All right, so kind of lowers my. It's kind of when I'm talking when I'm kind of building a differential for this problem. I'm wondering is prime? I mean, is this and caused by an ovarian issue? Is it caused by a GnRH issue, some kind of pituitary issue, or perhaps it could be iatrogenic or due to her overall weight status? Um, the lack of headaches, visual disturbances kind of lowers my the possibility of a pituitary issue a little, and the lack of hot flashes and night sweats decrease the risk. I mean, the likelihood of primary ovarian insufficiency. Oh, national gymnastics champion. All right. Yeah, so for a woman, oh yes, right. She's never been sexually active. So whenever a woman comes to the clinic and with amenorrhea, secondary amenorrhea, or even primary amenorrhea, I believe the first one of the first tests you have to do is a pregnancy test. She has been never been sexually active. BMI is 20, so actually not too low. Muscular woman, all right. If this BMI were super low, I'd be worried about some type of anorexia or female athlete triads. That doesn't appear to be the case here. Muscular woman, mild facial acne, but no facial hair. All right, so maybe a little bit of hirsutism, but not outright virilization. Breast and pubics are Tanner stage 5. Okay, 19-year-old normal external genitalia, vagina, normal cervix, small mobile uterus, no adnexal masses, TSH and prolactin levels are normal. What is the most likely diagnosis in this patient? All right, so it's still kind of unclear to me, but I believe that the musculature could definitely mean that she is using anabolic steroids, or maybe she's in transition. That's a way a lot of these people get anabolic steroids. They say that they want to transition to being a male and they can get it. Um, Regardless, though, I'm going to go through these answer choices one by one since I'm not still not super sure. Anabolic androgenic steroid use, that's something I was talking about earlier, could definitely be it. When you're using these steroids, you can just kind of screw up your own levels of estrogen, progesterone, or FSH and LH, and that just causes amenorrhea. CAH, it could present later. There are some variants that present later. However, this patient's blood pressure is okay. And this will be a kind of a strange presentation at this late of an age. So I'm going to cross that off. Hypothalamic amenorrhea, unlikely. TSH and prolactin are normal. If that were the case, TSH and prolactin will be low. Ovarian fibrosarcoma. Um, this is a type of ovarian tumor, I believe, that can secrete abnormal levels of. I'm actually not sure about this. Here, let me look that up. And I guess one benefit of this series is that I can look up answers immediately and explain these things. I can explain things that I normally would not explain. So these are a type of sex cord stromal tumors. I have this cool app that allows me. I mean, I labeled a lot of sketchy photos, but oh yeah, sarcomas, fibromas. All right, perfect. Let's take a look. All right, so this is my labeled sketchy, and here it says interested sarcoma fibromas. These are benign, cause a big pleural effusion, and Meg syndrome, in which they have this ascites-like belly swelling. You just, I remember the mnemonic that I was taught for this was um, imagine a bro fibroma, and the bro is a frat bro who loves to drink and gets ascites. So that's how you remember that. The ascites is pretty high yield. It doesn't say anything about sex, like about virilization, so I doubt it's that. All right. Oh, sorry. Back to the screen sharing. All right. So we're pretty sure it's not that. PCOS, she's more likely to be overweight in that case, and it seems like she doesn't really have a lot of the other findings we would suspect, such as glucose resistance and all that stuff, or like acanthosis nigricans. It doesn't specifically say that in the question, but we can. But I'm pretty sure this won't be it. If she had it, they would mention it in the stem. Primary ovarian insufficiency. She doesn't have any risk factors. She did not undergo any sort of chemo. She doesn't have a history or family history of that. No hot flashes or night sweats. So overall, that's pretty unlikely. Subclinical hyperthyroidism. No, TSH is normal, and if this were the case, we'd see elevated TSH. Yeah, so I'm gonna go with androgenic steroid use. God damn it. Functional hypothalamic amenorrhea. Athlete's triad. Yeah, that's one thing I discussed. Yeah, so I even brought up this female athlete triad. Low GNR, women with this condition decrease GnRH with a subsequent decrease in LH, resulting in estrogen deficiency. Okay, but that doesn't really tell me anything, right? First, I have to decide how I got it wrong. And it seems like that anabolic steroids, why was that ruled out? Let's see. They can cause hypertension and virilization. They also cause aggressive behavior and mood disorders. Okay, but just okay, whatever. So it doesn't actually say why not. I guess it's more likely to cause hypertension and aggression. Okay. All right, so it seems TSH is going to be low. Subsequently, decreased OH secretion and estrogen deficiency results in decreased bone mineral density. Yeah, I know that, but okay, I guess that because she's so athletic, GnRH drops and subsequently FSH and OH drop too. Um, Prolactin is going to be normal, I guess because that pathway is not affected. Um, but GnRH is still affected. All right. So it's more of like a functional hypothalamic amenorrhea as opposed to a structural issue. I think I was leaning too much towards a structural etiology, and that's how I messed up. All right. So the lesson here is that if you are suspecting a female athlete syndrome and there are no signs of gross virilization, lean more towards hypothalamic amenorrhea than androgenic steroid use. Oh, this is a double. All right, next step in management. So this is a management question. 32-year-old gravid woman, follow up at 28 weeks. So at the very end of the second trimester. No gestational diabetes, perfect. I was just gonna ask about that. Dietary modification, okay, low carb diet, 3 small meals, 2 snacks. Okay, that's good. Fasting glucose levels, not great, but not, I guess, tolerable. Most of her 2-hour postprandial blood glucose levels are above 140. Okay, so we might have to go up. Um, so no symptoms actually. Okay. BMI 38, blood pressure elevated, pulse 76. Urinalysis as shown. Yellow, negative for glucose, negative for protein. Okay, so she is not. So the glucose is elevated, but she's actually not losing it in her urine. Okay, that's interesting. When you're managing this type of diabetes in these pregnant patients, the typical agents that you associate with diabetes management, such as metformin, all that stuff goes right out the window. You have to either use dietary modification if it's not super severe, or you just jump straight to insulin. In this particular case, I guess she could lose weight, and I guess in real life we would encourage her to do that. These values aren't terrible, and quite frankly, I feel like if this happened in real life, it'd be up to the clinician's discretion. Uh, but yeah, these values, I guess, would be a little bit concerning for me as well. Um, what should I do? Realistically, she's not going to lose weight. Pioglitazone, no, you don't use this for management of for gestational diabetes. Canaflosan, no. UTI risk is too high. It's also not an agent you use for gestational diabetes. She's already made some dietary modifications. I'm just going to go with insulin for this one. All right, and that is the right answer. All right, good. Oral anti-glycemic medications may be used in patients who decline insulin or have difficulty adhering to insulin therapy. All right, so I guess they do have a purpose and a place. However, they're definitely not the first line. Dietary modification and exercise are recommended, but um, weight loss is actually not recommended due to an increased risk of a small for gestational age infant and possible preterm delivery. Okay, I actually didn't know that. That's pretty cool. Yeah, because I guess we always track their growth, and typically, if they are obese, we don't. I feel like I've never seen clinicians make a concerted effort to get them to lose weight, so maybe that's why. Despite starting recommended therapy, all right, sorry, first question first. What of the following is the next best step in management? Let's take a look. All right, management question. It seems like the patient's actually laboring. This is a pretty big baby at 8.8, so I think this actually hits the cutoff for macrosomia in a patient with diabetes. Spontaneous labor, protracted labor course, pushing for 3 hours, following delivery of fetal head. Okay, the anterior shoulder cannot be delivered yet. This is a big baby. Tight nuchal cord is palpated. Oh boy, that means like the cord is right around the neck, and it's a pretty dangerous situation. Typically, you have to actually feel for the cord when you're pulling the baby out, and I guess in this case, they felt it. The patient instructed not to push. Okay, that's the first thing you do. Which of the following is next step in management? You would not try to apply traction because if you do that, the neck cord is just going to become tighter. Clamp and cut the nuchal umbilical cord. Um, just moving it is not an option here, which I find kind of odd because I feel like that's the thing you do. I've never seen any other way this is done. I guess you could do this. Yeah, I don't know. Flex the patient's hips against her abdomen. I believe this is some special maneuver that you can do to free the shoulder. I don't know how it specifically applies to a tight nuchal cord. Emergency C-section. No, I feel like there are better options. There are better ways for us to manage it. Replace the fetal head into the maternal pelvis. No, you wouldn't do this either. This would just, I think, hurt the mother a lot, and you'd probably have an increased risk of rupture as well. Kind of between Bravo and Charlie for this one. The thing is, I'm not really sure how you might not be able to clamp and cut the cord, since in this case the cord is still within the mother, and it's going to be pretty hard to identify and cut it. So I'm going to go with Charlie, kind of flex the patient's hips against her abdomen. This way, I feel like the cord will be kind of lengthened slightly because the body is now bending more. All right, and that seems to be the right answer. All right, impaction of the anterior shoulder, obstetric emergency. Dislodge maneuvers to dislodge the anterior shoulder. Initial step is the McRoberts maneuver, flecting the patient's back against her abdomen, applying suprapubic pressure. Oh yeah, I've seen this done before too. Like the nurse literally jumped on the bed and then immediately started applying suprapubic pressure and doing this. So that's very cool, actually. All right, I guess this is more of a case of just regular shoulder dystocia as opposed to the nuchal cord, because I guess I was too focused on the nuchal cord and kind of missed the shoulder dystocia part. So I kind of had the incorrect reasoning, but stumbled upon the right answer anyway. All right, I guess that's a win for me, even though I'm going to mark this because I probably wouldn't have gotten, because I feel like I kind of got this question wrong. All right, this is a vulva question, which is the most likely diagnosis, lots of vulva stuff. Vulvular pruritus in a 54-year-old. All right, that's sometimes burning and preventing sleep. All right, patient has had increasingly painful defecation. That's interesting. Vulva blood after intense scratching. All right, so this kind of suggests to me that the vulva is kind of thin. In a patient like this with vulvular pruritus, most common cause is just vulvovaginal atrophy. However, you'd still be concerned about lichen simplex chronicus, since that is sorry. You would be concerned with lichen sclerosis because that is associated with cancer. Um, I believe the main difference between the two is that vulvovaginal atrophy tends to be more generalized, whereas lichen sclerosis can occur in a more localized area. Let me just double check to make sure I'm not saying the wrong information. Yeah, that's good. Yeah. So I was right. Yeah. So lichen sclerosis, you have this parchment-like condition, and yeah, it can be pretty itchy. All right. Applying skin moisturizer daily, not sexually active, alopecia, areata. Okay. Symptomatic hot flashes. So this could mean that she's not getting enough estrogen, but we'll see. Excoriated, pale, thin skin. By its bilateral, labia minora is not visible, severe narrowing of the introitus. Perianal skin appears white, appears wrinkled, and small anal fissure as well. One of these is the most likely diagnosis in this patient. All right, so actually, I might have been wrong earlier when I said that vulvovaginal atrophy is more generalized. Lichen lichen sclerosis can also be really generalized, and in this case, for instance, it's actually generalized all the way to the anus. The pale, thin skin part of it also kind of points me to the direction of lichen sclerosis, since that's usually kind of considered a pathognomonic feature. Atopic dermatitis, that can happen, but you'd see like blisters, it'd be very erythematous. You wouldn't see, there'd be excoriations, but it wouldn't be pale. Lichen planus, it's like purple polygonal, seen with Hep B patients. I mean, sorry, hepatitis C patients, I believe. Again, that just doesn't really match the description we are seeing in this particular case. With lichen chronic simplex chronicus, this can occur in really old or really young people, just itching, and it does cause itching, but it's not associated with any cancers. I think in terms of appearance, it's more of like a plaque with that's kind of thickened, and that's not what's being described here. Pinworm, no, this will only affect the anus. Vulvovaginal atrophy, yeah, I kind of discussed this earlier. It'll be kind of limited to the vulvovaginal area. If they hadn't mentioned this part about the anus, I would have picked that, but I'm going to go with C because they also mentioned the anus. All right, and yeah, it seems like that was the right answer. Vulvar lichen sclerosis has often has perianal skin involvement. All right, in a figure 8 pattern. Okay, that's cool. And let me see if I was wrong. I was right about everything else. All right, so their reasoning for ruling out vulvovaginal atrophy was pretty similar to mine. It does not typically affect the anus. And with lichen simplex chronicus, this happens secondary to recurrent scratching. Okay, so I guess that's that. Yeah, because when you scratch an area repeatedly, like I do with my hand, for instance, you can sometimes get these plaques that can form. So I guess these people scratch their vulva too much. All right, next question. It's the cause of symptoms. All right, so it seems like this is a diagnosis question. 29-year-old infertility. So many different causes. Unprotected intercourse over the past year has not become pregnant. Okay, so this is kind of describing that this is an official diagnosis. LMP was 3 weeks ago. Menses occur pretty normally. Severe lower abdominal pain that's partially relieved by ibuprofen. All right, this could be pretty important here. It could point towards endometriosis, some kind of structural issue. She was treated for gonococcal cervicitis. All right, so I'm really thinking, is this some type of PID or maybe endometriosis? Husband is normal. All right, yeah, because you always have to check the husband. BMI is slightly elevated. This is PCOS. Small normal uterus with a cervix that appears laterally displaced. There is pain with cervical manipulation. Which of the following is most likely cause of infertility? All right, so in this case, we kind of have three clues in the very beginning. One, severe lower abdominal pain, which you would see in during menses, and that's kind of endometriosis. Two, you kind of have this history suspicion for PID. Three, you kind of have this BMI that's kind of suspicious for PCOS, and all three of those can cause infertility. Um, Kind of ruling out the answer choices that aren't related. Endometrial polyp, no, that's going to bleed, but it's not going to cause infertility. It'd be exceptionally rare. Intrauterine adhesions, this is kind of related to PID. I'm going to leave it on for now. Submucosal fibroids, no, I mean, that could cause infertility, but I feel like it's very uncommon. And also, you wouldn't have a small uterus. Unicornulate uterus. So this is a structural problem in which when during the development of the uterus, it kind of has a horn going down the middle. Sorry. Don't think it's that. Otherwise, I feel like you wouldn't make this diagnosis unless you had some imaging of the uterus itself. All right, so we're kind of between PID and these in terms of intrauterine adhesions and endometriosis. Both of these can cause the cervix to be laterally displaced, but only one of them, the endometriosis, sounds like it's going to cause lower abdominal pain right before menses. Um, both of them can cause pain with manipulation. Both of them can be seen in overweight individuals. So, yeah, I lean more favor of endometriosis because of the pain part. If she's having active PID, this would be a different story too. But in this case, that's not the case. All right, endometriosis is the right answer. All right, endometritis may cause cervical motion tenderness, intrauterine adhesions that lead to infertility. However, patients have an abnormal vaginal bleeding rather than regularly timed menses. And also, endometritis does not cause lateral cervical displacement. Okay, so maybe I was kind of wrong about the PID thing, but I think my reasoning was solid enough for the rest of the case. Endometritis causes abnormal vaginal bleeding rather than regularly timed menses. Okay, I actually didn't know that. That's not sure if that's high yield or not, but all right, I guess that's good to know. Next question. This is a management question in a patient who is pregnant. She's at 28-year-old, 30 weeks gestation. Bleeding after a motor vehicle collision. All right, that's very concerning. Restricted by lap and shoulder belts. Uterine cord struck her in the abdomen. Pants are soaked with blood. Not sure if her water broke. All right, so yeah, definitely very concerning. Blood pressure is kind of low. Pulse is high. Probably want to get a peripheral IV in this person. Rest of the vitals look okay. She's alert and anxious. Abdominal tenderness, cool extremities. 100 milliliters of blood is evacuated from the vagina. All right, that's not good. I'm thinking, could she have abrupted because of a trauma? Minimal active bleeding from the cervix is observed. Blood type is O, Rh positive. Fetal heart monitoring 140 with minimal to moderate variability. Yeah, that's a little bit concerning. The thing is, you can't really use fetal heart rate tracings to there's no category for these patients. I remember one of my attendings chewed out a resident for saying that she was category 1 or 2 when she wasn't actually giving birth. Apparently, you can only use those category tracing numbers when they're actually giving birth. No variable or late decelerations. So, all right, contractions every 3 minutes. IV fluids are started, which is the next best step. Yeah, the concern for some kind of abruption here is pretty high. Definitely concerned about it. And this is 30 weeks, so still viable, not ideal, but I just don't know about this minimal to variable variability here. In real life, you definitely get an ultrasound to see if there's any blood behind the placenta or something, but we don't have that information. BP, just gonna cross some things off. Emergency C-section, maybe. Fetal BPS, that takes forever. You're not gonna do that here. Kleihauer Betke test, that's like for maternal blood mixing. You probably would already have that, and it's not gonna do anything in an emergent situation. Transfused blood products, maybe, yeah, maybe. She seems to be kind of hypotensive and tachycardic. Probably wouldn't transfuse her right away. Yeah, I don't think this is a next step per se, although she might require this later on. She definitely requires fluids, and those already have been started. Vasopressor therapy, no. She wouldn't really. She's obviously hypovolemic. Giving pressors is not going to really fix that problem. Yeah, so I guess the only thing it would be emergency C-section then. Let's see if this is right. Nope, it's not. Do not do an emergency C-section. Wait, the problem admits that, okay, she probably has a abruption, this can cause hypovolemic shock. Oh, because this is causing hypovolemic shock. We need rapid resuscitation with products of intravascular volume and transitioning to blood products. So my reasoning was right, but I got the wrong answer anyway because I felt that blood transfusions could wait a little bit longer. All right. All right, I guess blood transfusions are more urgent than I thought it would be. Normally we get a labs, we get type-in screens, but I guess in this particular problem, that's not really how it works. Massive transfusion protocol, all right. Yeah, you would activate that if you're going to transfuse a lot of blood, and this case seems like it's going to need a lot of blood. You wouldn't do a C-section because you would need a category 3 tracing. All right, fair enough, I guess. I guess you could use these categories on the test, and you have to have a category 3 tracing in order to get an emergency C-section. I don't know how they would know that this is not going to get worse, because abruptions can hold a lot of blood. You definitely get some imaging in real life to see how much blood was being held there. I guess a blood transfusion makes sense before you even get that ultrasound. All right, so I guess the reason I got this wrong was that I was too conservative when it came to giving blood. Next question. Management question. Which of this best management for this patient? All right, so management question, breast issue, 41-year-old nipple discharge, 2 episodes of blood-tinged discharge from the right breast only. All right, so when it's only from one breast, you can kind of rule out any type of endocrine disorder typically. So if it's prolactinoma or something like that, you'd have it in both breasts. Slightly increased number of headaches. It's kind of pointing me towards endocrine, but I think that the right breast part is pretty conclusive. It doesn't say she has a mastectomy, right? Yeah, it doesn't say that. All right. All right, combined OCPs. Last menstrual period was 2 weeks ago. She should stop taking them in light of these headaches, but whatever. Right breast exams is pretty normal. Scant discharge from the right nipple. Examination of left breast is normal. Mammography is normal. Oh, they even did a mammogram. How nice. Which of the following is the next best step in management? Yeah, you wouldn't use a breast ultrasound for this. That's for younger patients. You just don't do it unless you suspect there's a cyst or something. We don't see that here. Discontinuation of OCPs. I think she should, but maybe it's not the best next step. Empiric antibiotics. No, this is a pretty convincing case of just that kind of ductal disease in which you get intraductal papilloma, in which you just get a bunch of junk building up in the mammary inside the actual ducts. MRI pituitary, no, you wouldn't. So yeah, you just when it comes to that condition, intraductal papilloma, you just reassure and just continue to live and do regular workup. Okay, I was wrong. All right, apparently you do a breast ultrasound. Most common causes of papillary tumor. All right. Typically benign, not palpable on exam. However, they might have areas of atypia. Wait, so what did I do wrong here? I'm confused now. All right, so I guess the answer choice is trying to say that this is probably caused by a intraductal papilloma, which are typically benign. However, they may have areas of associated atypia, ductal carcinoma in situ, and intraductal carcinoma. So is it saying that the intraductal papilloma is kind of covering up all of that? I really don't know. Ultrasound is better at detecting non-calcified intraductal lesions that can cause nipple discharge. Uh, maybe this is more of a protocol thing. Imaging in woman plus 30 include mammography plus breast ultrasound, which in combination increases detection of intraductal lesions that commonly cause nipple discharge. I mean, I guess. All right, whatever. I guess this is more of a protocol thing, and you have to positively identify the duct. Okay, I think I understand it now. So instead of me just kind of making the diagnosis of intraductal papilloma based on symptoms and and physical exam findings, to actually want to confirm it via ultrasound. So that's why I got this problem wrong. I didn't think you would need to confirm it with imaging, but apparently you do. All right. I guess that makes sense. At least in the testing situation. I feel like in real life, I feel like you'd be pretty comfortable making that diagnosis, but whatever. Uh, all right. Which of the best contraceptive option? All right. So lots of contraceptive options here. This woman, 25-year-old, G2P2, postpartum visit, discussing contraception. Last week had a vaginal delivery. This is going to be pretty important here since she's going to be breastfeeding and you can't give some certain medications when she is breastfeeding. She has conceived while breastfeeding after first pregnancy. All right, yeah. So you definitely want some pregnancy options. I'm sorry, contraceptive options. Chronic medical conditions, no medications. Pelvic exam is deferred. Which of these is the best contraceptive option? Well, um, the exam loves copper IUDs, and I think these non-hormonal options are definitely better in breastfeeding patients. Combined OCPs, no, this would throw off her breastfeeding. Diaphragms and condoms are just never really an answer on these exams unless they're talking about STDs. These just simply aren't really good long-term options. Endometrial ablation, no, you wouldn't. This is going too far. You wouldn't go do surgery for this. Progestin only, they're not bad yeah, that's going to mess up the breastfeeding too. Subdermal progestin releasing implant, I'm pretty sure that's going to mess up the breastfeeding as well. All right. So copper containing IUD is not a good idea. Oh, I forgot. I kind of skimmed over this part. She takes a daily iron supplement for IDA and due to heavy menstrual bleeding. And in these cases, you cannot give a woman copper IUDs tend to make menstrual bleeding worse. So I guess that's a contraindication. I skipped right over that when I was reading the question. All right. So I guess you would do progestin and you would use the oral contraceptives do not affect breastfeeding or thromboembolic thromboembolic risk. However, they're less effective because of higher risk of user error and short half-life. Yeah, they have to be taken within the same hour every day. All right, so I guess this makes sense. I got this wrong because I misread the question or skipped a important part of the question. Typically in these problems, whenever I see something wrong, I just or like a contraindication, I just go off right to the answer and cross it off. That way I don't forget. In this case, though, I didn't even read it, so I had no chance to do that. Most likely cause of patient's hypermagnesemia, and also you can see that these are typically kind of difficult questions at least, and these are all questions I've missed before. And sometimes I repeat the same mistakes as well. It's kind of annoying, but just have to, you live and you learn. Hypermagnesemia. All right. So it's causing what is causing this elevated magnesium level. Lots of different options. G1, 36 weeks gestation, high blood pressure reading. Blood pressure is still high on arrival. Elevated serum creatinine and transaminases. So this is likely HELP. Nifedipine and magnesium sulfate are administered. Induction labor with oxytocin. 6 hours later, blood pressure is not as high, but still kind of high. Laboratory exam are as follows. Calcium is okay. Magnesium is 9.2, so pretty high. Which of the following cause of hypermagnesemia? All right, so the absorption of medications such as magnesium can be affected by a lot of other things. Magnesium is going to be renally excreted, so I guess renal insufficiency could cause it, at least in theory. Oxytocin toxicity that can cause hyponatremia, but it wouldn't cause hypermagnesemia, hypocalcemia. No, that's causes that would you typically this goes hypocalcemia goes hand in hand with hypomagnesemia and vice versa. You wouldn't see hypermagnesemia. Hepatic insufficiency, liver has nothing to do with magnesium. Drug interaction, let's see, what did you get? Nifedipine, calcium channel blocker, and magnesium sulfate. Is she on any other medications? And oxytocin. Yeah, I don't really see any of these medications interacting, quite frankly. It's like completely different pathways. Except for nifedipine, which I guess they're both acting on calcium, but again, the calcium level is high, so I don't really suspect that the calcium is causing this. So I'm going to go with renal insufficiency. All right, good. I got this one right. All right, yeah, good. Magnesium is secreted by the kidneys. Renal insufficiency is a risk factor for toxicity. All right, that's good. Yep, exactly what I expected. Perfect. All right, we're a quarter of the way there. What's the following next best step in management? A lot of different management stuff. I believe this is some kind of a birthing problem. 25-year-old, 33 weeks gestation, intermittent contractions that began after intercourse. All right, 10 to 15, now 1 to 2 minutes. Drink some water, but contractions continued. So this looks like it's real labor. It's not just Braxton Hicks because the duration's getting shorter. All right, fetal movement's normal. UTI caused by group B strep that was treated with antibiotics, prenatal care otherwise uncomplicated. Last ended with a term vaginal delivery. Temperature is good. Blood pressure is good. This is a category 1 tracing. Contractions every 5 to 8 minutes. On speculum exam, 3 millimeters dilated. No evidence of rupture of membranes. What is the best next step in management? All right, so this baby we're pretty sure is going to be coming. Okay, sorry, I misread the question. 10 to 15 minutes, lasting for 1 to 2 minutes. Now it's 5 to 8 minutes. All right, this is still true labor though, so I feel like it's going to be too late to actually stop this thing. This birth is probably going to happen at 33 weeks. I think it's acceptable. Bed rest and pelvic rest, no, that's not going to. You just probably would just lean more towards just delivering her in this case. Clear cause, that's too late. The horse is already bolted. Betamethasone you would give since this is still before 34 weeks and you want their lungs, and betamethasone can give enough time for their lungs to develop. Magnesium sulfate, that's before 32 weeks you would give this. She's not hypertensive, so you wouldn't give this prophylactically. Rectovaginal group B culture, no, you're not gonna get that back in time. You might do a quick swab and a PCR, but realistically, she's gonna give birth pretty soon, and you probably would just give some antibiotics just because you don't know if she's colonized at this point, and the baby's gonna come out any minute now. So yeah, I'm just gonna go with IM betamethasone, and that's right. All right, so for the group B strep part, these patients are because she had group B strep bacteria, she is considered persistently colonized. All right, so I guess that's okay. So I guess you don't even repeat that test, even if you had time. You just give the penicillin. All right. You see the medication being given out a lot on the wards. That's probably why. Also, if they had GBS, a previous baby who got infected by GBS, you permanently assume that they have GBS, and you give penicillin or augmentin for all the following children. All right. Next question, diagnosis question. Absent menses, vaginal delivery 4 months ago, has not had a menstrual period since. All right. Secondary. So this is secondary amenorrhea. Postpartum hemorrhage requiring blood transfusion and sharp curettage. So two situations are happening here. One, the sharp curettage could have injured her uterus. Blood transfusion could have injured her pituitary. She was started on oral contraceptives, and 2 months ago, uh, no vaginal bleeding or spotting during her week of placebo pills. Okay. Tardive pregnancy, regular menstrual periods, increased fatigue, and is bottle feeding. All right. So this kind of points towards a pituitary issue. I think this is Sheehan syndrome when they have these issues, and she's bottle feeding. So she means like some of these mothers don't lactate, but she's bottle feeding. All right. Clear vaginal discharge, well rugated vagina. Small anteverted uterus, bilateral small and non-tender ovaries, FSH and LH levels are actually normal. All right. So even though I was kind of leaning towards a pituitary issue before, a pituitary issue would cause a low FSH and TSH. You see low estrogen as well, since the pituitary is not working. However, you have a well-rugated vagina, which means that estrogen levels are good. So that just kind of leaves out a structural cause. That would just be Asherman's. Proof of basic disease, no, she's not having any symptoms. She's not throwing up or bleeding. PCOS, no, you wouldn't develop that so suddenly. You'd also see high FSH levels. Postpartum thyroiditis, no, you see low TSH. Primary ovarian insufficiency, no symptoms. You'd also see high FSH and OH. Sheehan syndrome, yeah, we discussed that earlier. Yep, and that's right, Asherman's. Oh, and you would do what's called a progesterone challenge, which is you just give progesterone and see if there's any bleeding at all. If you administer the progesterone and they bleed, it suggests an endocrine issue. Whereas if you give progesterone and it doesn't bleed, it means that the uterus has undergone some damage, and that's the case we see here. Next question. Which of the following pathogens is causing this patient's symptoms? Infectious diseases. Diagnosis question. 24-year-old woman, vulvar pain and dysuria. Past 2 days, no symptoms before this. Trip to the Caribbean 2 weeks ago. All right, intermittent fever and malaise on the trip. Patient sexually active, no chronic issues. Group shallow ulcers with surrounding erythema. It's painful. Left inguinal lymph nodes are tender to palpation. Urine culture is negative. All right. So pretty much all these diseases are going to be on the differential. I'm going to say whether or not they're painful and how we can rule them out. Chlamydia trachomatis, this can cause typically asymptomatic, but if there are symptoms, if, for instance, if you get LGV, the inguinal lymph nodes are tender, but you wouldn't get these shallow ulcers. And these ulcers, like the genitals, should not actually hurt, just the inguinal area. So I know it's not this. Haemophilus ducrei, you kind of get these, you tend to get a single ulcer. This patient does travel, so I guess it's possible. I don't know if you get inguinal lymph nodes or not. Let me see. Also have this cool sketchy file that I labeled. How do I share? All right, so LGV again, painless ulcer, but painful grooves. This is Haemophilus ducrei. So it's painful, tender lymph nodes, and bubules, yellow-gray base. All right. So I guess it could be it. Yeah, I'm just gonna leave that on there for now. HSV, I believe, is the most likely one. Quite frankly, it's like shallow ulcers with surrounding erythema. Ducrete tends to be like one big ulcer. Klebsiella granulomatous. This is also called like donovanosis. This is completely painless. Mycoplasma genitalium. I don't even know what this is. I'll go over that later. Doesn't sound like it's going to be painful though. Mycobacteria tends to be kind of a less painful thing. Treponema pallidum, syphilis. You get ulcers, sure, but the ulcers are pretty painless as well. Yeah, so let's see if the HSV part is a false. Let's see if the Caribbean part is a false herring, is a red herring. All right, good. It is HSV. All right, yeah. So like I mentioned, the Haemophilus ducrei ulcers are larger, deep ulcers, well demarcated, friable base. All right, so it's actually not because it's a single ulcer. These ulcers just tend to be larger. Large. Wait, no, I was right actually. Patients have a single large, painful genital ulcer. All right, so yeah, that's that. I was actually right. So Haemophilus ducrei, it tends to be one ulcer. HSV is multiple ulcers. Next question. Which is following next best step in management of this patient? Oh boy, we have a lot of labs, so lots of workup stuff. I'm guessing she has a headache. 34 weeks gestation, emergency department, found unresponsive. Unconscious about 30 minutes ago, gradually became responsive again, nausea, vomiting, severe headache, no symptoms other than the headache, migraines. She has a history of migraines, no medications. Blood pressure looks good, slightly high, but not too concerning. Pulse 78, respiration is 20, cranial nerves intact, supple, fundoscopy is normal, lungs are clear, normal heart sounds, uterus looks good, minimal pretibial edema, DTRs are 3 plus. Not sure if this is pathologic or not. Lab results, hemoglobin looks good, platelets look good, leukocytes slightly high, but not super concerning. Slightly low, but not super concerning. Good, 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 good. Good, good, good. Protein 1 plus, not too worried. Ketones are present. Okay. Suspicion for DK is not high, quite frankly, given that glucose is 80. So maybe this is just like a pregnancy type of thing. None of these CTE shows bilateral frontal lobe edema, but no mass lesions or bleeding. Which of the following is the next best step in management? I really don't. This is one of the ones where I don't really have a diagnosis. Doesn't sound like it's meningitis. Doesn't sound like it's because of hypertension. Doesn't sound like it's infectious. Doesn't sound like it's because of some kind of mass or acute, some kind of acute ischemic or hemorrhagic stroke. Let's take a look at the answers. CT venography. So this is this is pointing at a cerebral venous thrombosis. Could be. Pregnancy is kind of a hypercoagulable state. Yeah, so that could be it. And you would get mostly reassuring physical exam findings as well. CT scan's not necessarily going to show that, oh yeah, you'd have some edema. So yeah, I guess it could definitely be this. Lumbar puncture, you do this if you suspect meningitis or acute bleed, like subarachnoid or something. And in this case, it's just like the neurological normal temperature, normal there's no nuchal rigidity and all that stuff. No, yeah, normal physical exam, so I feel like LP you're not going to do. Magnesium sulfate infusion. You might do this 34 weeks. Yeah, 34 weeks. You're not going to do this prophylactically, and her temperatures are not, her pressure is not super high. She's not have preeclamptic. Uh, yeah, I wouldn't go there. You might do it in real life. You might just give this just because, but yeah. Triptan abortive therapy, that's for migraines. This doesn't sound like a migraine to me. She passed out for crying out loud. Video EEG, no, she doesn't have a history of seizures, and it doesn't really sound like a seizure. She was found unconscious 30 minutes ago, gradually became responsive. You might have headache with seizure, but I still feel like it's kind of, it'd be kind of weird. It'd be strange for her to kind of get a seizure out of nowhere, especially if the video EEGs are for what, like epilepsies, and you be pretty hard pressed to get that. Yeah, so I'm going to go with CT venography since like this is most closely associated with pregnancy. God damn it. All right, so you would actually give magnesium sulfate. She is hypertensive. Is that why they're giving it? Consistent with eclampsia with severe features. What? Oh, okay. I was too. I rushed the question again. So it says blood pressure is 139/98. This is severe features. All right. Protein is only 1 plus, but I guess that's enough. All right. Well, this is preeclampsia with severe features. Host-ictal state, severe headache, hyperreflexia, elevated creatinine levels. Eclampsia requires magnesium sulfate. All right. It's not central cerebral venous thrombosis, which can cause the same thing. However, CVT causes papilloedema and focal neurological deficits. Okay, I actually didn't know that. I thought CVT causes no focal neurological deficits. So I guess it's good that I will now remember this. CVT can cause it's pretty severe pain. I've seen that. I've never seen focal neurological deficits, but there we go. I guess you learn something new every day. So I got it wrong because one, I wasn't careful in reading the question. I forgot this 98 part, which was consistent with her features. I also thought that the protein would be higher if she actually had preeclampsia. Well, now it's eclampsia because she had a seizure. I also thought that a CT venography would actually have a blood clot in the cerebral venous system would cause a focal neurological findings. It doesn't do that, apparently. I mean, sorry, it does cause focal neurological findings in real life. So yeah, two things I can learn from that question. All right. Next question. Might have to go on break in a little bit. My voice is getting kind of tired. Which of the following is the next best step in this patient? All right, so this is a workup question. 57-year-old G1P1. She's been feeling well, walks, plans on retiring, sexually active, no pain in intercourse, late menstrual period months ago after a lapse since age 53. Yeah, that's a little bit alarming. Whenever a patient without who's like kind of postmenopausal comes in and randomly has a period, it needs to be worked up. It could be endometrial cancer. All right, family history is okay. Drink socially. PAP was mammography and PAP were normal 2 years ago. Good. BMI is 28. Good. No, not great, but okay. This is America. Which of the following is the most accepted in evaluation? So, diagnostic laparoscopy. So when you're kind of evaluating for endometrial cancer, you want some kind of a sampling from the endometrium. If that's abnormal, you would get some kind of imaging. Diagnostic laparoscopy, I think that's going too far. You wouldn't do that. It wouldn't be your first line. Hysterosalpingogram, this will allow you to kind of see the uterus, but I don't think you can, effectively determine whether or not you have endometrial cancer. MRI, yeah, you could, but um, again, you kind of, if she has signs of it on like kind of sampling of the endometrium, you go to this to see if it has spread or not. I don't think this will be first line though, since like you'd be pretty limited in what you can get out of from the endometrium, how much you can actually see there. You definitely do additional evaluation. FSH, no, you wouldn't do that. At least not first line. Your first concern is going to be um, ruling out cancer. So I do a biopsy. It's not a type of surgical biopsy. The way you don't have to actually cut the patient open and go into their uterus. I think you can just kind of get a stick and scrape a little bit of the endometrium off. You could go in through the cervix. Alternatively, I think you can just pump water into the uterus, collect some cells from that, and use that for analysis. So it's not a very invasive procedure. I go with endometrial biopsy, and that's right. Require a pap test for cervical cancer and either endometrial biopsy or transvaginal ultrasound to evaluate for endometrial cancer. Okay, so actually you can use ultrasound. I didn't know that. I don't know what you will be looking for. Oh, okay. So you would be looking for the endometrial thickness, and if it's less thick, then less concern for cancer. I guess that makes sense. It's not exactly, it's more of a correlation thing, but I guess it works in real life. Yeah, so you would just, yeah, so you could use ultrasound or do an endometrial biopsy. Yes, so I guess I still got it right. I don't think I'm going to mark that. All right, I'm going to pause a little bit. I'm probably going to end this video here. It's already been going on for 1 hour, and I'll be starting part 2 soon.